Oh my God. Doctor, I can't breathe. You gotta help me. Don't you worry, ma'am. We're gonna do everything in our power to get you feeling better. Based on your history of COPD and the positive COVID test that we noted from 2 days ago, we do suspect that you're having a COPD exacerbation. We're gonna do our diagnostics, our testing, our blood work, all of that to make sure we know what's going on, and we're gonna treat your symptoms as well. We're gonna have our stellar BCIT students go over the pathophysiology, the oxygen supply and demand, the primary assessment, and the interventions, as well as the emergency medications, so we keep you in the loop. Thanks, Doc. I know they'll do a great job.
This is our presentation on COPD exacerbation for Emergency Nursing Theory 1. It was created by Jenna, Kate, and Olivia. We will be covering the pathophysiology of COPD exacerbation, followed by how this applies in oxygen supply and demand. The signs and symptoms evident during the primary assessment will be explained, and then what interventions can or should be occurring during the first assessment. Additional medical interventions to aid in the acute management will be laid out, including a full list of potential emergency medications. We will conclude with a Kahoot quiz.
As the COPD patient continues to have exacerbations, the disease progression worsens. In chronic bronchitis, thick mucus and hypertrophied bronchial smooth muscle cause airway constriction, leading to narrowing and obstruction. This airway obstruction leads to mismatched ventilation perfusion ratios in the alveoli, causing hypoxemia. In emphysema, obstruction results from inflammatory and destructive changes in the lung tissues. Alveolar destruction produces large air spaces within the lung parenchyma and adjacent to lung pleurae. These large spaces cause impaired gas exchange and result in ventilation perfusion mismatch and hypoxemia as well. In both COPD diseases, obstruction causes air trapping to occur in distal lung areas, resulting in hyperinflation and expansion of the thorax. This puts the respiratory muscles in a position of mechanical disadvantage, causing increased rate of breathing that leads to decreased tidal volume, hypoventilation, and hypercapnia. Increased heart rate results from low arterial oxygen saturation as the heart works harder to meet oxygen demand and pump oxygenated blood around the body. As COPD disease progresses, increased pulmonary hypertension in the right ventricle leads to cor pulmonale with right heart failure, therefore resulting in decreased stroke volume and poor cardiac output.
So regarding our oxygen supply and demand, our oxygen supply is decreased due to the emphysema and the chronic bronchitis, which was talked about on the last slide. Our oxygen demand, on the other hand, is increased, seen with the tachycardia and tachypnea. Hypoxemia is seen due to the decrease in gas exchange, and then hypercapnia can be seen when carbon dioxide cannot be adequately excreted. This leads to a ventilation perfusion mismatch. The decreased oxygen supply of the lungs cannot keep up with the demands of the body. This can result in respiratory acidosis, with that CO2 retained. Beginning with airway, as patients with COPD are at risk for airway complications, safety equipment such as artificial airways, a bag valve mask, the oxygen, and suction should be readily available. When assessing the airway, the prevalence of dyspnea, coughing, wheezing, or increased secretions such as mucus can be present. These symptoms can be due to the fibrosis and inflammation, causing decreased airway patency, loss of elasticity of the lung tissues, and emphysema, as well as limited gas exchange. Moving on to breathing. During this exacerbation, breathing can be accompanied by tachypnea, labored or pursed lip breathing, utilizing the tripod position to facilitate ease of breathing, and minimal breath sounds on auscultation can all be present. Due to the body's inability to move oxygen in and out of the alveoli, hypercapnia is a primary symptom, as well followed by hypoxemia, which can be present after. This indicates an unsuccessful gas exchange through the lungs. Moving on to circulation. When assessing this patient, some circulatory specific findings can include cyanosis, peripheral edema, and changes to mental status due to the limited oxygenated blood flow to the brain. Some more chronic features of a patient with COPD include clubbing of the fingers due to long-term decreased oxygenation of the small capillaries and rounded barrel-like chest caused by the overinflation of the lungs. Depending on the body's ability to circulate oxygenated blood, cyanosis may or may not be present. Tachycardia, which is commonly seen with an acute COPD exacerbation due to hyperventilation, increases the oxygen demand of the heart and decreases cardiac output. With increased oxygen demand from the lungs and decreased oxygenated blood being pumped from the heart, this can lead to further circulatory issues. Chest pain can also be seen with this condition. In regards to disability, assessing the patient's Glasgow Coma Scale and AVPU can help determine a baseline level of consciousness and orientation, as well as changes which could be altered due to hypoxia. It is also important to assess any pain the patient may be experiencing, as well as their level of urgency. This could also be any changes that would indicate an expedited need to see the doctor. Next, it would be important to expose the patient, changing them into a gown to allow for further assessment of chest movement with inspiration and expiration. It would also be important to note any changes in skin color, such as cyanosis, the skin's temperature, or any trauma or bruising to the chest that could impair chest movement and breathing. This would also allow for further assessment of the skin regarding circulation. Next, completing a full set of vital signs, including an SpO2 reading to measure the oxygenation levels, can help determine the need for further interventions. Assessing the heart rate, respiratory rate can also provide insight into the client's work of breathing. The vital signs can help indicate improvement or deterioration of the client's condition. Moving on to go back and assess, it is important to reassess the patient's work of breathing, the efficacy of the supplemental oxygen, as well as assessing lung sounds. It's important to monitor for changes in the level of consciousness, ensure that the airway is patent and maintained, and that the oxygen saturation is adequate.
COPD exacerbation can range significantly depending on the individual patient's course of disease and their ability to compensate. Therefore, immediate intervention during the primary survey may be required. If the airway is deemed inadequate, endotracheal intubation may be warranted. This is appropriate with mechanical ventilation in the presence of deteriorating ABGs and mental status with progressing respiratory failure. The first line of primary survey intervention for severe exacerbation is non-invasive positive pressure by face mask. It works by reducing the work of breathing by maintaining lung volume, which exists due to the ventilation-perfusion mismatch causing dead airspace. If this is an ineffective therapy and the patient continues to deteriorate, a move to mechanical ventilation may be required. High-flow oxygen delivered via nasal cannula is the primary delivery method of choice, as it is easily controlled to allow permissive hypoxia. In COPD patients, permissive hypoxia with a target pulse oximetry of 88 to 92% is appropriate because the hypoxic drive is muted as chemoreceptors have developed tolerance to chronically elevated arterial carbon dioxide levels. Therefore, permissive low oxygen levels are vital to maintaining respiratory homeostasis. There is a ventilation-perfusion mismatch, which results in increased dead airspace and therefore less effective oxygenation. Pulse oximetry application will provide additional information to support adjusting therapy. Intervention during breathing assessment with bronchodilators or other nebulized therapy can also make a significant difference in relaxing the airways. Finally, it is important to be aware of and follow patient advance directives and most scores when considering primary survey interventions. As respiratory acidosis in acute exacerbation changes patient ABGs, cardiac function is impacted. Therefore, heart monitoring is important to maintain awareness and be able to intervene readily. While most pharmacological therapies will be delivered via inhalation or oral routes, IV access is important for electrolyte balancing as well as antibiotic administration. For continued orders and interventions, the emergency physician needs notifying as well as respiratory therapy. In preparing for chest x-ray and CT, the patient can be changed into a gown. Family at the bedside will support maintaining patient calmness. Finally, a full set of vitals with SpO2 to monitor hypoxemia, respiratory rate to monitor distress, heart rate, blood pressure to monitor poor cardiac function, and regarding the poor ability to oxygenate blood in the lungs, temperature to monitor viral bacterial causes of exacerbation will provide valuable information to guide adjustment or addition to any previous interventions. A focused respiratory assessment will aid in identifying varying degrees of worsening dyspnea, increased sputum volume, and purulence in addition to increased wheezing, cough, upper respiratory infection, or respiratory rates. Interventions guided by the assessment include patient positioning. Do they need to be sitting up more or helped into a tripod position? Expiratory clearance. Is there more sectioning required or should oral fluids be encouraged? And encouraging breathing exercises to increase ventilation capacity, such as pursed lip breathing, deep breathing, and controlled coughing, and diaphragmatic breathing. Pulmonary function tests, which are also used to diagnose and monitor stable COPD, provide information regarding residual volume, total lung capacity, forced expiratory volume, and vital capacity. These can be compared to patient baseline as well as to monitor intervention efficacy. Cardiac monitoring is important to assess for any arrhythmias and potential heart deterioration, particularly right-sided heart failure associated with cor pulmonale. Laboratory tests include a complete blood count assessing for infection, anemia, and polycythemia. Arterial blood gas analysis is warranted for evaluation of pH status, serum carbon dioxide, and serum bicarbonate, as the chronically elevated arterial carbon dioxide levels make the blood trend towards acidic anyways. Renal compensation occurs as the kidneys attempt to reabsorb more bicarbonate. Assessing ABG will provide information on the degree of maintained compensation. Blood cultures can show the distribution of potential infection, and a CNS can be completed on a sputum sample to aid in determining appropriate therapy. Imaging includes chest x-ray and CT. X-rays may show hyperinflation, flattening of the diaphragm, and increased anterior-posterior diameter, as well as possible bronchial wall thickening in chronic bronchitis cases. CT would show central lobar emphysema, bronchiectasis, malignancy, bullae, or is good for surgical preparation. If an infection is present, imaging will also identify the infection site and possibly the agent.
Albuterol is considered a short-acting beta agonist, or a SABA. It works to relax bronchial smooth muscle by acting on beta-2 receptors with little effect on the heart rate. For COPD exacerbation, a metered-dose inhaler, or MDI, or nebulizer is preferred for administration. Combining a SABA with a short-acting muscarinic agonist, or SAMA, provides greater symptom improvement than monotherapy. Ipratropium bromide is an example of a SAMA. This medication causes bronchodilation by blocking the action of acetylcholine at parasympathetic sites in bronchial smooth muscle. Both of these medications cause bronchodilation in the airway. Oxygen demand increases during a COPD exacerbation as a result of altered work of breathing from airway inflammation and narrowing. These medications result in the relaxation of airway smooth muscle, increasing diameter and decreasing resistance in the airway. This helps to increase oxygen supply to the lungs, thereby increasing arterial oxygen saturation. Systemic corticosteroids such as oral prednisone are used in severe COPD exacerbations. When the patient cannot tolerate oral medications, IV methylprednisolone is recommended. This medication decreases inflammation by reversing increased capillary permeability and suppressing the migration of polymorphonuclear leukocytes. It also suppresses the immune system by reducing activity and volume of the lymphatic system. The normal immune response during a COPD exacerbation results in airway edema, bronchospasm, and increased sputum production. This medication decreases the inflammation in the airway, thereby increasing airflow and oxygen supply to the lungs and increasing arterial oxygen saturation. Magnesium sulfate is considered a mineral and electrolyte supplement. However, it is also used as an effective bronchodilator in severe COPD exacerbations. This medication works by inhibiting calcium influx into airway smooth muscle. In turn, this relaxes bronchial smooth muscle, thereby increasing oxygen supply to the lungs and increasing arterial oxygen saturation. It is only used when the patient is not responding to initial therapy. Bacterial infections are a common cause of COPD exacerbations. Azithromycin is a commonly used antibiotic in the emergency setting for COPD exacerbation. This medication kills and prevents growth of bacteria by inhibiting RNA-dependent protein synthesis. This reduces airway inflammation caused by normal immune response towards foreign bacteria. Decreasing airway inflammation helps to open the airways, allowing increased oxygen supply to the lungs and increasing arterial oxygen saturation.